Now we come to the second part of AMEBAE. It may be commensal and opportunistic AMEBAE will be discussed here. The first is Entamoeba hartmanni. Entamoeba hartmanni was considered before a small race of Entamoeba histolytica. They were calling them magniform and minutiform. The magniform is the pathogenic Entamoeba histolytica, and the minutiform is the non-pathogenic Entamoeba histolytica, which is lumen-dwelling and never penetrates the mucosa. It is morphologically very similar to Entamoeba histolytica, but smaller in size. The cytoplasm contains only bacteria in the food vacuoles, no RBCs like Entamoeba histolytica. There are serologic differences between it and Entamoeba histolytica, and it is considered non-pathogenic, so doesn't need treatment. Here we can see the trophozoite and cyst are similar to Entamoeba histolytica. The second is Entamoeba coli, which is more common than Entamoeba histolytica actually. It is non-pathogenic amoebae closely resembling Entamoeba histolytica. So many cases are given treatment or else some cases of Entamoeba histolytica are not treated as they were thought to be Entamoeba coli. In the morphology, the trophozoite differs in size. It is larger than Entamoeba histolytica, about 50 micromillimeter. The cytoplasm is all granular. There is no discrimination into ecto and endoplasm like that in Entamoeba histolytica. And the food vacuoles don't have RBCs. Also, it has sluggish movement with short pseudopodia made of granular cytoplasm and not hyaline like those of Entamoeba histolytica. Nucleus is lined with coarse irregular chromatin, and karyosome is eccentric, not in the middle like that of Entamoeba histolytica. In case of cyst, the cyst is larger, being 35 micromillimeter. It has 8 nuclei easily seen in fresh preparations. Also, the chromatoid bodies are sharp, thread-like. This is the diagram. This is the diagram of Entamoeba coli, and this is the slide showing the nucleus with coarse chromatin and the eccentric karyosome. Here is the cyst with sharp, long chromatoid bodies and nuclei which are similar to that of trophozoite, and they are 8 in number. On every focus, if we see more than 3 nuclei, we consider that it will be Entamoeba coli. Here we can count 5 nuclei at the same focus. The third type is Entamoeba gingivalis. Entamoeba gingivalis is present in the gums, and it is similar in morphology to Entamoeba histolytica, and it is present also in between teeth in pyorrheal pockets in the patients of pyorrhea. It is also present in tonsillar crypts in case of chronic tonsillitis and sometimes on bronchial mucosa in case of chronic bronchitis. This amoeba is a commensal amoeba which feeds on tissue debris. So if there is pus, if there is tissue debris, it goes there for feeding. The cytoplasm is granular. Food vacuoles contain bacteria and ingested leukocytes. The thin arrow shows that this is a nucleus of segmented leukocyte here, and the thick arrow shows that the nucleus is similar to that of Entamoeba histolytica. Cytoplasm is granular with food vacuoles containing bacteria, ingested leukocytes, and this is characteristic for Entamoeba gingivalis. Also, it has no cyst stage, and this is also characteristic for Entamoeba gingivalis. It was suspected to cause pyorrhea, but it is now considered a commensal which grows and flourishes in case of pyorrhea or any other chronic inflammation. Now we come to the free-living amoebae. The free-living amoebae or opportunistic amoebae are called opportunistic because in some people they are commensal and in others they cause severe pathology. They also are called coprozoic amoebae as their cysts may appear in stool, but they are swallowed and pass along the alimentary tract without changing, and thus they come from one end to go to the other end without any dealing with, so they are called coprozoic amoebae. Most cases of pathology are due to Naegleria, one species of free-living amoebae, which causes primary amoebic meningoencephalitis or PAM. It is also called amoeboflagellate. It is also called amoeboflagellate as it can transform into a flagellate form, and some cases are due to acanthamoeba which never produces flagella as in Naegleria. Now we'll speak about Naegleria fowleri. Naegleria fowleri is an amoeboid, has an amoeboid phase alternating with a flagellate form that possesses two flagellae when in fluid media. It occurs within the body in the amoeboid form only. It is present all over the world in tropics and subtropics, and the infection usually occurs during swimming. It is diagnosed by finding the amoebae in the CSF. Flagellation can occur by adding distilled water. Amoebae can be active in room temperature. It is characterized by the nucleus having a large caryosome. Clinical picture: the course of primary amoebic meningoencephalitis is dramatic, acute, rapid course. The prodrome begins 1 to 2 days. There is headache, fever, nausea, and vomiting. There is affection of the olfactory, frontal and temporal, and occipital areas. There is neck stiffness or rigidity, seizures, positive Kernick's sign, and the olfactory area affection with disturbances of smell and taste can occur. Also, coma and death follow within 3 to 6 months. Only one species of Naegleria is pathogenic and can be detected by serology, which is Naegleria fowleri. This is a picture of Naegleria inside the brain. See, it is hematogenous dissemination here. There is inflammatory cells around, mainly eosinophils, here and here. Mainly they are eosinophils with double nuclei. Also, this is the brain matter like ground glass around the trophozoites with dark nucleus due to the large chromatin in the nucleus. These are two trophozoites also in the amoeboid form with the nucleus and large chromatin around the caryosome. Spinal puncture examination: purulent turbid CSF comes out in the syringe. It is highly cellular, mainly neutrophils without bacteria. It has high protein and low sugar content. RBCs are present and also motile amoebae can be seen. They have sluggish movement with blunt pseudopodia. Primary amoebic meningoencephalitis is a relatively rare disease with worldwide distribution. It is recorded from young, healthy persons. All gave history of swimming in swimming pools, hot springs, rivers, or lakes in summer, or in heated swimming pools in winter. Reports are more in developed countries than in underdeveloped countries. This may be due to their awareness with the disease. Sorry. Treatment is not yet satisfactory. Amphotericin B is the drug of choice, and it is given intravenously and sometimes intrathecally in severe cases. Prevention is by public education, medical care awareness, and chlorination of water supply and swimming pool. The second type, Acanthamoeba species, this is the other cause of pathology from free-living amoebae. It was first thought to be Hartmanella, but now Acanthamoeba is known to be the pathogenic one. It is characterized by the long, slender, spiky acanthocyte acanthopodia, not pseudopodia like other amoebae. It can be found on the mucosa of upper respiratory tract. It can produce chronic CNS infection known as granulomatous amoebic encephalitis or GAE, and a serious eye infection which is acanthamoeba keratitis and a granulomatous skin infection. This occurs near the bed source. CNS infection is not associated with swimming like that in Naegleria. It is blood-borne or comes through circulation secondary to infection of skin or lower respiratory mucosa. It is a chronic infection, mostly in the immunocompromised patients. Keratitis occurs in normal, healthy persons, highly related to the use of contact lenses or eye trauma. And Acanthamoeba castellani is mostly found in the CNS and eye infections the same. But Acanthamoeba astronix and Acanthamoeba palestiniensis can cause only CNS manifestations, while that Acanthamoeba hatcheti and Acanthamoeba polyphaga, cause only eye infection and don't affect the intestine. So you can eat from them. Diagnosis occurs by finding trophozoites in the CSF or both trophozoites and cysts in the brain tissue and in the CSF. Cysts are never found in case of primary amoebic meningoencephalitis, where the trophozoites only are present. Amoebic keratitis can be diagnosed by corneal scrapings, examination, and culture from them. Species identification is by immunofluorescent antibody staining, and amoebic keratitis also is characterized by causing severe ocular pain. This is not the case in herpes simplex keratitis, so we can differentiate between them by the level of pain in the patient. Here is a picture of the trophozoite of acanthamoeba with the acanthopodia coming from the cytoplasm like this. Here is cross-section from tissues showing the cyst of acanthamoeba. It is characterized by having double wall here and here because the wall is very thick here and here. This is also another cyst of acanthamoeba. This is another cyst of acanthamoeba, and this one also. Clinical picture of granulomatous amoebic encephalitis is a chronic infection characterized by focal granulomatous lesion in the brain. The onset is accidental. Incubation period is not known. There is change in mental state, headache, seizures, nausea and vomiting, neck rigidity in half of cases. but not all the cases. The disease is focal granuloma with trophozoites and cysts beginning around a blood vessel from the inner to the outer parts of the brain. There is primary similar pathology in any organ affected. And the primary usually is an intestinal ulcer or skin ulcer or from chronic bronchitis and the passing through the circulation to lodge in the brain or in other organs. Thank you for your patience and listening to our lectures. Wish you the best of luck.